With this, I think we proceed to the next session, for which we have a very eminent gastroenterologist as chairperson. We have Dr. Devendra Desai, who is a consultant of senior consultant of gastroenterology at PD Hinduja Hospital. Welcome, sir. And we have Professor Atul Sachdeva, ex-director of Government Medical College and Hospital, Sector 32, and presently a consultant at Max Hospital in Chandigarh. Over to you, sir.
Thank you. Is Dr. Devendra there, or should I introduce Vineet?
Okay, let's start, Dr. Sachdeva.
Yeah. You please go ahead. Introduce Vineet.
Okay.
Go ahead.
So now we have Professor Vineet Ahuja from All India Institute of Medical Sciences, and we all know Professor Ahuja, that he is original thinker, excellent clinician and researcher, and a very nice human being. So I invite Professor Ahuja to start his talk, please.
Thank you, Dr. Desai. That was a very, very effusive introduction. I really liked it. As a kind of introduction you would like to have it on an evening dinner or something like that. Something which you would really love. Now, I was supposed to talk about improving outcomes in acute severe ulcerative colitis, lessons from India. And I thought that first and foremost, I must bring to record the legacy of PGI in terms of organizing meetings on ulcerative colitis. For the young people, they must be thinking that meetings on ulcerative colitis must have just started 2-3 decades ago, because it's a disease which was not supposed to be very common. But actually, the first ever meeting, I think, somebody may correct me, but that is what I could gather. The first ever meeting of ulcer on IBD was held by Professor P.N. Chutani. It was held in 1964, conducted in Chandigarh, and 136 cases of ulcerative colitis were presented. And a few years back, Professor Rakesh Kochhar and Dr. Ajay Kumar, they also conducted a one-day seminar on acute severe ulcerative colitis, whereby threadbare each and every aspect of acute severe ulcerative colitis was discussed, and it has subsequently also been put in tropical gastroenterology. So in other words, acute severe ulcerative colitis has been something which has been in the eyes of the Indian gastroenterologists, and they have been looking at various methods on how to approach it and how to improve the treatment for the aspects of it. So in one slide, I am going to give you the gist of management of acute severe ulcerative colitis, and subsequently, what are the efforts which have been made in terms of improving this algorithm. A patient of acute is diagnosed as acute severe ulcerative colitis based on true love and Witts criteria. Subsequently, he started on IV hydrocortisone or IV methylprednisolone, given for 5 days. Along with that, antibiotics may be given, may not be given. The response is assessed at day 3, via day 3, because that seems to be a fairly good predictor for assessing the response to 5 days of IV steroids. And at day 3, one can simply look at bowel frequency and also look at CRP levels. And based on that, categorize patients as being complete responders, incomplete responders, or non-responders. And if patients are complete responders, by day 5, one can switch over to oral steroids and add azathioprine. Whereas those patients who do not respond well, obviously they need another form of therapy, which may be in the form of medical therapy like infliximab, or it may be in the form of cyclosporin, or some patients may go in for surgery. Now, the questions which were brought about a few years back were, one is that are patients with acute severe ulcerative colitis in India distinct from West? Can we recognize this failure? Because day 3 seems to be very important, because if you can recognize this failure early and spot on, then your chances of improving the management are much more. So early recognition of failure, can it be done? Your patients are given IV steroids, and over 3 to 4 decades, this has been the mainstay of treatment. So can we increase the steroid response rate somehow? Biologics are required out here. When the patients do not respond, then often they are sent in for biologics, they are offered biologics. So is there an alternative strategy to biologics? Because that's a high cost of therapy. There are adverse events associated with biologics, so can we decrease the adverse events associated with biologics? So going over these 5 questions, first part of the work, I would say, like most of the work which has been done out here, which has been collected over various centers of the country, one would realize that most of the work has been done by DM students as part of the thesis, and that is, I would say, very, very heartening, and that is what I would call as the team India. So first part of this work is one which has been done by Saransh. Saransh was a very illustrious father-son combination. late Professor Akejan, Saransh and Saransh's son, both of them were from AIMS, and Saransh did this work around 3 years back. And first basic question was that, okay, can you apply TrueLove and which criteria for diagnosing acute severe colitis in Indian population? Because hemoglobin is low. So if hemoglobin is low, obviously one of the criteria straight away goes away. But the message from the study was that you can apply TrueLove and which criteria, even if you find lower in hemoglobin, because rest of the variables, they take over. Second point was that if you want to have a more objective measure, then fecal calprotectin can be a good measure. Fecal calprotectin in higher values, somewhere above 800 or something like that, has a reasonable diagnostic accuracy to diagnose acute severe ulcerative colitis. In India, in a tertiary hospital, how many patients generally present with acute severe ulcerative colitis and what happens to them? So it was seen that around 10% of patients, they present with acute severe ulcerative colitis. And of these 10% of patients, in the first time only when they're admitted, 10% of them, they undergo surgery. And overall, 1/3 of them, they undergo colectomy, suggesting that this is a marker of aggressive disease. That is the main point out here. In fact, when the follow-up was seen for over 5 years, 10 years, it was seen that if a patient develops acute severe ulcerative colitis, there's a 1/3 chance that over 10 years, the patient will definitely have colectomy. There's a 50% chance that the patient may have a repeat episode of acute severe ulcerative colitis. In other words, telling you that this is a marker of aggressive disease. So if a patient has developed acute severe ulcerative colitis, you need to optimize the treatment. And obviously, these rates are not so much different from the Western countries. These are rates, okay, over the last decade or so, when TNF in India was not so much in vogue. Yet at the same time, these rates are not so much different from Western countries. That is the first. Second point is predicting failure of IV steroids. These are short-term outcomes that on day 3, you are able to predict the failure of IV steroids with the help of Oxford criteria, and that has been used everywhere worldwide, which is to look at CRP and stool frequency. If you find that CRP is high, stool frequency is high, or only stool frequency is more than 8 per day, there's a very high chance of colectomy. The problem with this is that many of these patients, they have incontinence. Then it was thought that Indian population as such, the CRP values were not seen to be very high. So is it possible that in India, the sensitivity specificity of these criteria may be low? So it was thought that let's look at more objective criteria which are available. The more objective criteria could be endoscopy score, that is baseline sigmoidoscopy is done in all these patients at admission. So you look at UCEIS score and also check for fecal calprotectin, which can be checked at admission as well as day 3. And it was seen that if you find a high UCEIS score, endoscopic index of severity is high, more than 6, and on day 3 you find high fecal calprotectin values more than 1000, there's a 100% chance that there's going to be failure to IV steroids. And subsequently, it was again validated. And once it was validated, it was seen that it was seen to be better than Oxford criteria. The AIMS index was performing much better than Oxford criteria. In fact, if you even take, the problem is that, okay, if you do not have fecal calprotectin results which are available on the same day or point of care tests are not available, then at the same time, if you only do sigmoidoscopy on admission, even sigmoidoscopy on admission has a high predictive value in terms of predicting failure to IV steroids. So this reminded me in fact of like most of the slides were made yesterday evening when I was watching the match, because obviously you couldn't miss yesterday's match. And so it seemed like an India-England match. And we must have seen that in most of these papers, Simon Travis has been one of the co-authors. So it was like, okay, the English talks to people, they develop this criteria, and now you're going to say that this criteria is better than the Oxford criteria. But at the same time, in all fairness, Oxford index can be done at any center. It requires just a CRP and the bowel motion count, whereas AIMS index requires a point of care FCP test. Point of care FCP test is not available at most places. So once it is widely available, once it is less expensive, this is something which will become a globally used index. And this is also, in other words, this is something, a state of art, which is going to come up over the next 2-3 years, which will be applied in many centers once FCP is available. This is something like, for example, if I look at a study done by Professor Kocher that was done in 1993, where the study talked about relapses of ulcerative colitis and what could be the possible reason, and they found out amongst the infections, Clostridium difficile rate was very high. This is before the Western countries had even started thinking about Clostridium difficile. That is the time it was found that of 32 patients with active UC, around 7 or 8 had a positive bacterial cause, and 6 of them had Clostridium difficile. Okay, so the next point is, can IV steroid response rates be improved? Now that we know that we can predict better outcomes at tertiary centers, so can the IV steroid rate response be improved? So this is the famous landmark study, Tulov and Joel study in 1974, where IV steroids were given for the first time in acute severe ulcerative colitis, and it was seen that the remission rates were around 73%. And subsequently, efforts have been made at improving the steroid response rate. And last decade, a systematic review came up, which pooled many studies, again showed that the response rate was still 67%. In any setting, if you give IV steroids in a cohort of patients with acute severe ulcerative colitis, the best responses you get are to the tune of around 70%. So the question is that how do you improve the steroid response rate? So is there something you can do? So microbiota obviously is different in patients with acute ulcerative colitis as compared to controls. This study showed that microbiota is also different in patients with acute severe ulcerative colitis when compared to patients with ulcerative colitis when compared to healthy control. The question was that, okay, how do you change the microbiota? Would you like to do fecal microbial transplantation in such a setting? It would be dangerous. So can you go one step higher? Let's change the diet. If you can provide something in the diet, and for patients with acute severe ulcerative colitis, and would that help in improving the steroid responsiveness? Because if we improve steroid responsiveness, obviously many of these patients will not have to go over to biologics. So that would be a big boon for the patients in this country. So Pavitro, who is our first IBD fellow, and this he did as part of his DM thesis again, he did a randomized controlled trial where he looked at exclusive enteral nutrition. That is 7 days of exclusive enteral nutrition. Here in this study, peptamen was given, but otherwise you can also give polymeric feeds also, because oligomeric and polymeric feeds are roughly similar in terms of efficacy. So exclusive enteral nutrition was given, and it was compared with standard of care, where 32 patients were there in EN arm and 30 patients were there in standard of care arm. This trial had to be stopped midway because of COVID. So as a result, we could not recruit too many patients, but nevertheless, when we analyzed, we found that patients, when an intent to treat analysis, patients who were on EN arm, they had less chances of steroid failure, although not statistically significant, and the duration of hospitalization was also much lower. When a per protocol analysis was done, it was seen that corticosteroid failures were much lower in patients who were on EN as compared to patients who were being standard of care, and the difference was striking. The difference was to the tune of 25%. When you looked at biochemical parameters, again, there were strikingly significant differences. Albumin levels were much higher in EN group, CRP levels were much lower in EN group, and fecal calprotectin levels were much lower in EN group as compared to standard of care. When a 6-month outcome was seen, then it was seen that although colectomy rates were lower but not statistically significant, yet the composite outcome of colectomy or repeat hospitalization was definitely lower in patients who achieved EN, who were in the EN group. There were changes in microbiome also which was seen. So in conclusion, based on this study, one would say that if we look at the analysis, either intention to treat analysis or the per protocol analysis, and look at the deltas, we find that just using a simple strategy like exclusive enteral nutrition, where the cost to the patient would be roughly 1,000 rupees a day is the cost for exclusive enteral nutrition at best, even if you use peptamen. So if you're going to use it for 7 days at the cost of 7,000 rupees, you're augmenting the corticosteroid responsiveness by to the tune of around 20% at least. So since it is first of its kind of trial, so the question is whether clinicians should now adopt the simple measure in addition to the standard of care, and that is obviously open to debate, and that further 1 or 2 years will tell us. But Oxford has already have started using EN in all their patients with acute severe ulcerative colitis. They are going for a change in practice. So that, in a lighter vein, I would say, reminded me of the T20 yesterday, and this was like India versus England, and so we won the T20 also, and that was a great match. Now, in the if you realize that one of the another interesting things about these matches was the audacious, innovative strokes which have started coming up. And obviously, this is like in the 4th test match, Rishabh Pant, he played an audacious reverse sweep, and it was very successful. So the question out here, again, lessons from India is, can you improvise and adapt? Obviously, because you need to do that. And so this is a great study which has come up, led by Dr. Ajit Sood. And this, they have named it also very temptingly as a miracle study. And the study design was very simple. The question was that obviously patients cannot afford infliximab as a salvage therapy for a long period of time. If a patient of acute severe ulcerative colitis, he does not do well, he's put on infliximab, then the patient may be able to afford 3 doses, but would not be able to afford more than that. What do you do in such a setting? So this was a retrospective analysis whereby patients were given patients who had been given induction therapy, they had achieved clinical remission, infliximab had been stopped because of economic reasons, and subsequently they continued on azathioprine plus 5-ASA. And the results showed that 77 patients who achieved clinical remission, if you look at 1 year, 2 year, 4 years, 6 years, 50% of patients you can say they did well for 3 to 4 years. And obviously that led to it was very, very cost effective, clearly suggesting this is an excellent strategy. This is a very innovative strategy. And it is not that innovative strategies have not been coming from India. In fact, we always thought about chloroquine we thought was a very innovative strategy for corona, but we never knew that chloroquine has also been used for active ulcerative colitis. This was a study done. Professor Atul Sachdeva was there, and he would recall the study was done late in 1996 when it was seen that chloroquine was found to be as effective as sulfasalazine in patients with moderately active ulcerative colitis. And in fact, the reason why it would not have taken off is because of the long-term side effects of chloroquine. And then recently Vishal has come out with a nice study which has looked at the role of antibiotics, whether antibiotics should be given in patients with acute severe ulcerative colitis. They did a randomized controlled trial divided into 2 arms where antibiotics were given and antibiotics were not given. Did not find any difference, but the whole thing is here I feel that there is a sample size is less, so as a result we cannot be very conclusive about it, yet at the same time it provides some good evidence to suggest that probably we have to consider in moving towards that area that antibiotics may be stopped. Finally, coming back to cricket. Cricket is that you have a mandatory power play. That is, you all know that T20 first 6 overs of an inning, there has to be mandatory power play. So there will be a lot of damage. So the question is that how are you going to control the damage? Can you prevent collateral damage? All these patients, when you give biologics, all these patients with acute severe ulcerative colitis and all, there is a high chance of TB. This is a meta-analysis done by Saurabh where he clearly showed that patients who were given biologics not only had anti-TNF therapy, they not only had a high incidence of tuberculosis, but this was totally dependent upon whether the person was residing in TB endemic area or not. It was not dependent upon ulcerative colitis or Crohn's disease. It was not dependent upon what dose. It was not dependent on infliximab. So the question is what to do about it in such a setting. And this study from G.V. Pant, Dr. Puri's group, was a very interesting study. Here they took up patients who were had IBD and also healthy controls. They wanted to answer the question, do you want to do only IGRA in these kind of patients? You want to do only TST or you want to do both? Because this is often a very debatable issue. And this study clearly showed that there are some patients who are positive by TST. There are some patients who are positive only by IGRA, whereas majority may be positive by TST and IGRA, suggesting that not only there's a good concordance between TST and IGRA, but for LTB screening, that is latent TB screening in IBD patients, TST and IGRA are complementary methods, and that needs to be done. So in other words, the strategy, what we thought was that there should be a very stringent screening strategy. Do not only TST, do also IGRA. TST, that is MON2, but also do a CT chest. Because CT chest, if it is better than chest X-ray in picking up tuberculosis, then obviously in latent TB also it should be better. Then go for liberal chemoprophylaxis, not only for patients who are TST or IGRA positive, but those patients who have recent contact with TB, previous history of TB, or old evidence of TB on CT chest. So previous history of TB is also very important. And this is a recently completed DM thesis by Piyush, and it showed that 2 cohorts, one cohort before December 2018 or January 2019, where 112 patients received anti-TNF at our center, cohort after January 2019, where 56 patients were on anti-TNF. And it was seen that after you implement this stringent screening and liberal chemoprophylaxis, when the complete TB screening rates go much higher, when you're doing CT in all 100% of cases, your IGRA rates also jump much higher, you find obviously the prophylaxis for LTB also goes up. And what you find out here is that you have a dramatic reduction in risk of tuberculosis TB reactivation after giving anti-TNF therapy. If you apply this strategy, simple strategy, there is no rocket science in it. It is just that we have been talking about it, but it's a question of whether you apply it very, very properly. Then you find by simply applying what everybody talks about, risk reduction of TB was from 17% to 1.8%. So coming back to the overall, what I would say, messages from India. then you find I have to go back to the Team India. Team India, maybe it's a cricket team, they won the test matches, they won the T20, so we are also happy, but it is a Team India, we here are the DM students. Because we would have realized that 80% of the studies which came up out here, or they were done by DM students as part of the DM thesis. And as they have come up with some interesting results, that is, you have a more objective criteria if you want to predict steroid failure early on, that is UC as day 0 and more than 6, and fecal calprotectin day 3 more than 1000. If you want to augment steroid responsiveness, exclusive enteral nutrition seems to work very well. Obviously, it needs to be validated. If you have given patient salvage therapy in the form of infliximab induction in after acute severe ulcerative colitis, you can stop it. There's a fair chance that 50% of patients will do well for 3 to 4 years with just azathioprine for 5 years, say. And if you are afraid that the patient will develop TB after infliximab therapy or adalimumab therapy, just screen them very, very well, give them liberal chemoprophylaxis, and that should help. And finally, what about the future? I think I've reserved one study because I have found again a DM thesis, and I thought that this I should put on the last slide to say that future, again, very interesting thoughts are emerging from the Team India of the country. This is a study from Chandigarh again, Jimil's DM thesis and Usha's a guide, where they talked about, Usha I think showed this study in a talk also, but it's a very interesting study where they found that all those patients who had the most severe disease, they actually had colonic mucosa associated candida, and that is obviously very, very good food for that. Thank you so much for your attention, please.
So,
Hi, Vineet. Thank you very much for a wonderful presentation. Am I audible?
Yes, sir. Thank you, sir.
Great, and great similarities shown with Team India, and of course, Team India is playing a great role in management of ulcerative colitis. Yeah, we eventually, of course, we'll have better outcomes, I'm sure. But when we talk, very interesting 2 or 3 things which I would definitely like to ask. One about the role of diet. I mean, you brought it out very well. So what would be your recommendations? What kind of diet can be promoted in, say, acute severe ulcerative colitis? Second, what would be your choice of antibiotics in management of acute severe ulcerative colitis?
So first thing is that in terms of diet, we would suggest to give exclusive enteral nutrition. That would be in the form of, like, you have peptamen or fesobin or remetin. Fesobin and remetin are the polymeric brands, and peptamen is the oligomeric brand. So they can be given around 80% of the patients are able to tolerate them well, and they can be given at 1 tin a day, which contains around 455 calories per 100 grams. The tin is 400 grams. So the cost would not be much. For fesobin or remetin, it's around 600 rupees a day. For peptamen, it would be 1,000 rupees a day. But that does seem to help. And not only I think it helps out here, I have a feeling it would also help because if they build up the albumin levels and the patient is not responding, then subsequently the patient has to be given infliximab or something. There a higher albumin level would also be very, very useful. So so it would be better than giving them the regular. Regarding antibiotics, as Vishal's paper showed, randomized controlled trial, IV ciprofloxacin and metrogel they gave to one arm, and they found that it did not provide any benefit in terms of, although the study had only 50 patients. Yeah. The question out here is that if a patient has toxic megacolon, leukocytosis, definite features of infection or some abdominal tenderness, then you would definitely like to give antibiotics. However, it's not necessary that you would give antibiotics in all cases, and you can pick and choose your patients where you will give antibiotics. I think that is a message we get from that.
Yeah, thank you very much. Any role for antifungals? I mean, this last slide that you showed.
So too early to say that, although they have published, Usha has published a study of fluconazole, I could not find it on PubMed. So they must be coming out in print, but at the same time, it's a little bit early right now for giving antifungals as such for all. That's what I said. This is a study for the future.
Yeah. Thank you. Wonderful. Dr. Desai, hello, Devendra.
Yes.
So,
basically, just wanted to have one comment that now we have stool biofire. And because this antibiotic are little tricky, we all give antibiotic, but we don't really have a evidence-based medicine on that. So we are having one study where we are looking at the biofire, which detects about 21 organism, and that will be helpful to really clarify whether infection does play an important role. So with that, I think we can stop this session, and thank you very much.
Thank you. Thank you. Thank you. Thank you. Thank you. Thank you, Vineet. Thank you. Bye.
Thanks, Vineet. I hope you have clarified a lot of confusion now for the evening.
That was a nice introduction, sir. Very, very nice.
Hello. Nice as usual.
Yeah. Be a great human being. Thank you. Thank you.
Thank you, chairpersons and the speakers. And for the next